Okay, here we go. 3, 2.
The broadcast is now starting. All attendees are in listen-only mode.
Hello
to everyone from rainy Chicago, and welcome to our live broadcast on COVID-19 and how it has affected us as cytology professionals and as human beings. Brought to you by the American Society of Cytopathology. And during one of our discussions, Dr. Pantanowitz suggested that we should have a panel discussion on COVID. As you know, we had Dr. Pambuccian give us a lecture on that and a webinar on that. And we said, well, what do we do in our daily lives? Maybe we should discuss that. And this was a great idea. Why? Because not a day goes by that our lives are not affected by the current circumstances. We wonder what are the best practices. We wonder, we consume news and scientific articles about this like we've never done before. We worry, am I doing the right thing at work? Am I putting my lab members in harm's way? Am I learning something during this time if you're a trainee? Am I teaching something if you're a faculty? Am I able to provide what is best for our patients? Am I increasing the risk of my loved ones at home, like kids, elderly parents, etc., to contract this disease as I come into the hospital and I see my patients? What else can I do to help? And this is true anywhere in the world and whatever our roles may be. So this panel is to get the perspectives of all who are in the trenches in some way or another, and to really show that we're not alone and rather we're all in this together. So let's go one by one through our panelists. So our moderator is our one and only Dr. Stefan Pambuccian, who is a professor of pathology and the vice chair of faculty development at the Department of Pathology at Loyola University Healthcare System in Maywood. And our panelists will go in order. Dan Rhoads, who is an assistant professor at the Department of Pathology at the School of Medicine. He's the director of microbiology at University Hospitals, Cleveland Medical Center from Cleveland, Ohio. And then we have Ms. Susan Alperstein, who's a supervisor at the Pambuccian Cytology Laboratory, Department of Pathology and Laboratory Medicine at Weill Cornell, New York. And we have Dr. Maureen Zakowski, who is a professor of pathology of molecular and cell-based medicine, but also she recently got her law degree, so we congratulate her on that. She's currently at the Icahn School of Medicine at Mount Sinai in New York. Then we move on to our West Coast panelist, Dr. Ghofrani, who is no stranger to the American Society of Cytopathology. He's done a lot for the society. He's the system medical director for the laboratory services. He's also the director of cytopathology and women's health at Peace Southwest Medical Center and Peace Health St. John Medical Center in Vancouver, Washington. Now, he has also a different perspective he will give in addition to the West Coast perspective. He's a trustee for the American Board of Pathology. So if we have any trainees online, any residents, fellows, he's the man to ask questions about the ABP. Then we move back to the Midwest to Dr. Liron Pantanowitz, also who needs no introduction to the society, is very well known. He's a professor of pathology and biomedical informatics, the director of cytopathology at UPMC Shadyside, and the director of pathology informatics fellowship program in University of Pittsburgh. He's going to make us jealous with all the telepathology methods that they have in Pittsburgh. And last but not least, we're going to end on a very happy note and learn about our psychologies and maybe how to even be happier and not be so depressed in these difficult times. And that will be from Dr. Timothy Bono, who is a lecturer in the psychological and brain sciences with a focus on positive psychology. He's the assistant dean for assessment and analytics in the College of Arts and Sciences in Washington University in St. Louis. and he's the author of Happiness 101, and we can't wait to hear about that. So first, I'll turn over the microphone to Dr. Pambuccian, who is going to be talking about a survey that we recently sent from the American Society of Cytopathology to see what is the status of our practices and our psychological well-being during these times.
Hi, everybody. Thank you, Dr. Barkan, for this kind introduction and for inviting me for doing this. I think that in the beginning I had some problems with this because we heard so much about COVID-30 that one more thing seemed to be a little bit too much. But then I realized that we need to share our experiences somehow, and I think that there is a good way of doing so. Thanks for the ASC to organize and sponsor this. And happy belated Papa Nicolau birthday and Cytotechnologist Day. And thank you for all you are doing. Our last webinar on this subject was 1.5 months ago. We learned some new things, but not much. But what we learned is how to live with this. And we also learned that we have to live with this for a lot longer than we expected. So today we are going to find out how to best cope with this from all aspects. We are going to find out how to cope with it psychologically, how to cope with this from more the business aspect of it, and so on. I will go through the survey results, and before I go, I will say that thank you very much, everybody, for participating in this and answering this pretty long survey. I think that it gives us a sort of a pulse of the status of what the cytology community is going through.
Yeah, thank you so much.
So there were 233 respondents, and 195 were from 39 states in the United States, 5 from Puerto Rico, 10 from Canada, and 29 from 21 other countries. Cytotechnologists were responded more than cytopathologists or residents, and there were more women than men. The median and mean age was 47.5, but there was a pretty wide range. Could you go next? Thank you. When we looked at how many inhabitants the city in which the respondents were working in, you can see that there is a very wide spread, and basically all types of smaller cities, intermediate cities, and even mega cities are represented in here in pretty much in the same amount. Next, please. Academic hospital, most of the respondents worked in academic hospitals, but you can see that there were also respondents working in community hospitals, private practice groups, and other institutions. When you look at the map of the United States and see where the respondents were from, mostly they were from the Northeast, but they were also from the Midwest and the West and all other regions of the country. Next, please. These are flowers from my front yard, backyard, and I don't know what their names are, but they give us a break through this pretty dense stuff that I'm having to show today. Okay, so the first question we asked is your work environment, do you perceive your work environment as safe? And it's interesting that only 39% of respondents thought that their work environment is safe. 49% thought it's sort of safe, but they don't have enough stuff.
There's only bronchopneumonia and then chronic inflammation in the kidneys. So,
and 9% thought that it's unsafe. So how about what to do with specimens received from patients with COVID-19 or suspected for COVID-19?
by now,
Some,
yes.
basically half and half do special labeling and don't do special labeling, but as you can see that most of the respondents treat all samples as if they would come from a COVID-19 patient.
But also,
Next, please. What are the samples that are received from
Pambuccian, if
COVID?
you don't mind me interjecting, would all the panelists please mute themselves? Joanne, if you have your microphone on, can you mute it too? All
When I came here,
right, go ahead, sorry.
right.
around 8,
As you can see,
they already called like 27 times here on the phone.
So I started video.
anyway, most of the samples from COVID-19 patients were bronchoalveolar lavages, but other specimens, fluids, CSFs, FNAs, were also received by individual laboratories. Next, please.
Okay, I went then. Okay.
Yeah.
When you look at the impact on specimen volume that this lockdown had, you can see that most labs have had a significant, more than 2/3 reduction
Good morning.
in the amount of specimens that they received. And that was most significantly seen in PAPs, but it was seen across the board in every other specimen. In FNAs performed by non-pathologists, FNAs performed by pathologists, and basically we are working at 1/3 of our capacity at best. Next, please. When we look at what the impact of this COVID-19 lockdown is on the staffing and compensation, basically 1/3 of labs didn't have any changes. 1/3 they redeployed some of their workers to other areas of the hospital. 1/3 has reduced its workforce through paid leave and vacations, and almost the same amount through unpaid leave, furloughs, and layoffs. And about 8% have reduced the compensation.
Somebody, and he was telling me for job and stuff,
Next, please.
telling me that a lot of people, they have been, especially in private practices, they lost their jobs. So everybody is looking for.
Oh, that is a bad thing for you guys.
So-
I know coming out from.
Yeah.
So anyway, the next question we asked is that if individual respondents have made any changes to their rapid on-site evaluation procedures, and most people did not. And I know that I'm going very fast over these numbers, but you all will get a copy of the survey results, so you can look at them. But importantly, most of the procedures on which rapid on-site evaluations were performed are performed in endoscopy and bronchoscopy suites, both of which are high risk because they use suction type of aspirations. Next, please. So at the question on, please go over this. The question that we asked is what the greatest fears are around this, and not surprisingly, the fear of infecting others, including family and loved ones, was the most important, more frequent than fear of getting infected themselves. And other fears like making mistakes at work were also common. Next, please. There is another interesting breakdown of concerns. You can see that the health of colleagues was a very important concern. And the second most frequently expressed concern was about the financial well-being of the laboratory of the hospital. And I hope that some of our panelists will address the economic impact of this crisis on the institutions that we are working in. As you can see, the next, we asked about what the coping mechanisms were. And we can see that most people coped by using some sort of a physical activity, walking, taking a break, and so on. And as we expected, maintaining daily routines seemed to be a very important coping mechanism. But the next three are discussion elements. So discussing problems with significant others, friends, and family. And the next most important one is limiting their exposure to COVID news, which I think is a very important one. And I am doing it lately. In the beginning, I was listening to all these things and I was getting more and more stressed. But the next slide, please. Other coping mechanisms were meditation, prayer, arts and crafts, music, painting, knitting, and so on. And 8% of our respondents were using some sort of a mindfulness app. And I hope that our psychologists on the panel will give us more details what an app would be that we could use on our phones to get us less stressed. Next, please. Next, please. So we are going to now discuss, we have administered two standard psychological tests, one that is addressing the level of stress and the other one that is addressing the level of depression. Next, please. So when you're looking at the perceived stress scale, we, as a whole, of all 159 respondents to these questions, we had a score of 16. And as you can see, a score of 16 indicates moderate stress. But that doesn't actually reflect the whole gamut of things, because some of our respondents had high stress levels and some of them had low stress levels, obviously. But what it shows is that the stress level in general across the board was 16. And next slide, please. Then on the depression scale, we are at the high end of the quote-unquote mildly depressed scores, which means that a lot of respondents were on the moderately depressed scores. And now we are going to see the breakdown of these to age, gender, marital status. And you can see that there is no difference according to age. But there is a small difference in favor of more stress in women and more depression in men. But I don't think that these differences are statistically significant, but we didn't do the stats yet. The marital status is significantly correlated with both more stress and more depression. And it's not surprising, because we saw that the most important coping mechanisms that we had for our respondents were discussing things with their friends and family. So not having that probably contributed to this. Next, please. We also broke the results down onto cytopathologists versus cytotechnologists and trainees. And you can see that the highest level of stress is in trainees. And I hope that our panel member that is in the American Board of Pathology will address some of the fears of the unknown that led to these very high levels of stress. Next, please. When we break down on regions of the country and stress and depression levels, I was surprised to see that the West has the highest levels of both. And I hope that Mohi is going to address the reason for that when he's going to talk about this. But the rest of the country seems to have very similar levels of stress, except for the Southeast that has had probably the least cases until this point. And I suppose that's why the level of depression is the lowest there. Next, please. When we correlated the depression and stress levels to the answers about how their work environment is perceived, it's not surprisingly respondents that had perceived their work environment as being not safe had the highest levels of both stress and depression. Next, please. Next. Okay, so we asked the next questions were about what are the positive things that this may have brought to us. And obviously, we started using all these teleconferencing software, and some of the respondents felt that that's a plus. Some of the respondents finished their unfinished projects because they had more time on their hands. Many people thought that there's a good opportunity to spend more time with their families. And basically, from now on, we will have a lot of e-meetings. So it's good that some people think that that's a plus. Next, please. So next, we asked, what are the changes that you're hoping that will become permanent? And the most frequently cited one was to have educational activities and using web conference software tools. And we will have much more of that because our face-to-face meetings or our physically meetings will probably be postponed for a while. And this is going across the board for even departmental meetings, educational meetings, and CME meetings. Next, please. This is very interesting because we asked what are the hurdles to implement whole slide imaging or digital signouts. And I'm sure that Liron will talk more about it, but probably is the only one who actually answered that they don't have any hurdles because they implemented it. And that's why he's so relaxed now and he doesn't have anything to do. So then most people don't have the capacity to do this because they either don't have the instruments or the hardware, they don't have people running the hardware, they don't have IT support, they don't have, and they don't know what the legal implications are. Okay, thank you very much for your attention. And we are going to take questions after all panelists have finished their presentations, and I will be looking for your questions and asking the panelists whatever you're thinking. And I'm happy to introduce Dr. Rhoads as the next speaker. And I will take myself off. Thank you.
Thanks so much for inviting me and giving me the chance to talk with all of you. So throughout the next few slides, I have QR codes. So if you want to follow along with some of the articles that I'm going to briefly discuss, you can use the QR code on your phone. Just turn on your camera app and it should link you to the article. This is a link to my Twitter page, just for practice. Next slide. So there are a lot of asymptomatic infections. People are infected with the SARS-CoV-2 virus, but they don't have COVID-19. So this was an interesting study in New England Journal of Medicine. They were screening L&D, people coming in to deliver babies, and they found that 89% that were positive for the virus did not have symptoms at the time of testing. So this is, previous slide, please. Yeah, so this is concerning or at least informative. So I know a lot of places and a lot of hospitals, and it's recommended, I believe, to, screen for symptoms, but just remember that most people who are infected don't have symptoms. So most of the virus in the community is not from people who are sick. They're people who are asymptomatic. So keep that in mind. I think that's important to recognize. Next slide. So for the last 2.5 months, I've been feeling like all I've been doing is SARS-CoV-2 testing and, what's the best test, what's not the best test, what about this test? None of the tests, I know, we're all pathologists or work in pathology. We recognize that not any one test is perfect. But I think the biology of COVID-19 is bringing to light that molecular testing on upper respiratory specimens really is not perfect for detecting people who are infected. One contributor to that is the time of testing. So as the disease goes along, the viral load decreases, or at least in the upper respiratory tract, the ability to detect the RNA from the virus decreases over time. So in this paper, this is a different paper in New England Journal. They noted that higher viral loads were detected soon after symptom onset and that they decreased over time. And also, the viral load was not that different between asymptomatic and symptomatic patients. So again, most of the virus in the community is coming from people who are asymptomatic, it looks like. Next slide. There's not, most of the studies looking at the sensitivity of testing, compare one platform to another. And that's helpful from a technical standpoint to try to figure out which test is most sensitive, but it doesn't put it in the clinical perspective. There's not a whole lot of studies that have looked outside of RNA testing to try to figure out how sensitive the testing is at a clinical level. This is one study that's that was published a while ago that I found very informative, that looks at a chest CT and compares it to PCR. And this might give us insight into the actual sensitivity of testing, the clinical sensitivity. If there's no virus in the specimen, the RNA test is going to be negative, but could the patient still be infected? And the answer is yes. And here they say, it's in a radiology journal, but they say, CT is a really good, really sensitive way to detect a COVID-19 case, whereas PCR is substantially less sensitive. Okay, next slide. This was just published in the last day or so, and it's a good reminder to people interpreting tests that how to frame the test results in pre-test probability, prevalence in the community when you're interpreting a positive or negative test result. And they pointed out, and I think this is important to remember and kind of sums up the previous few slides, that a positive PCR test for COVID-19 has more weight than a negative test because of the test's high specificity but moderate sensitivity. Next slide. Antigen testing, I believe today there is one antigen test that has received authorization from the FDA for emergency use. It's still not clear exactly how antigen testing is going to fit into the picture. Next slide. These are two different documents from the CDC that are very helpful. The biosafety guidelines for laboratories are very useful. If you're wondering, what should we be doing in our laboratory? Is it okay that I, do this or do that, or decontaminate here, or work in a biosafety cabinet, or don't work in a biosafety cabinet? This document is helpful for helping to answer some of those questions. And then the second document is not laboratory specific, but it talks more generally about infection control measures that can be used in the hospital to try to prevent the spread of COVID-19. So that's all I have.
Right, thank you very much. Our next speaker is going to be Ms. Susan Alperstein, New York.
Thank you. Next slide.
Slide coming up.
Reporting from the Papa Nicolau Laboratory at New York Presbyterian Weill Cornell. I'm the supervisor at the laboratory here, and I hope that you all got to enjoy Papa Nicolau's birthday National Cytotechnology Day yesterday. This is a tree that's planted in front of our emergency room in honor of Papa Nicolau. Next slide. Being the epicenter of the virus, we've had a huge impact on our laboratory. Starting from the beginning, our entrance to the laboratory, we have one entrance. Security makes sure that we are mask compliant. Probably being in New York, our biggest challenge was social distancing. Over here on the right, you can see a sign that shows how many feet apart you should be. These signs are posted around New York and the parks. So to deal with social distancing, we had to be creative and deal with a lot of changing of shifts, moving different areas into different workspaces, and sometimes deploying staff to other areas of the hospital. In our physical space, we undergo deep cleaning. And I think cleaning is one area, along with PPE, that you can empower yourself to feel like you're doing something to make sure that you're reducing transmission. And the cleaning is occurring in the non-clinical as well as the clinical spaces. Places like an IR are dedicated spaces to just COVID testing or testing all specimens. And as part of the WHO and CDC and our institutional guidelines, we did establish a blameless environment for workers to report incidents, and we encourage self-assessment and symptom reporting. The symptomatic employees stay home, and again, our institution was so generous with providing additional paid off time for staff that did not come for their PTO if they experienced testing, is now available also for all our staff. Next slide. Next slide, please. It's important very early on. Prior slide, please. It's important to have a biosafety risk assessment and really look at all the processes for preparation and adequacy from beginning to end to ensure that if you need to change any processes to mitigate transmission. Very early on, we decided that we were going to implement universal standard precautions, that is considering every case as a potential COVID-19. And this is, again, for, as you know, some history challenges, and also testing wasn't being done in the beginning and the early onset. And also there are those asymptomatic and false negative specimens. So we were processing all the non-GYN and fine needle aspiration cases in our biosafety cabinet, but our thin prep PAPs were a little bit more of a challenge. Now we realize that we also have to have complete PPE on in the preparatory room, and we've dedicated one thin prep processor. The T5000 is too challenging to disinfect, so we're not using that during this time. And if you dedicate certain pieces of equipment, you can make sure that those are thoroughly decontaminated. Another thing that we're doing that we didn't do before is we're wiping the outside of the specimen containers with a disinfectant wipe before we're storing them, just to ensure there's nothing on the outside. Next slide. So I've been very fortunate in New York Presbyterian. We have not had a shortage. We've had all the personal protective equipment that we've needed, and we've had it from the onset of this virus. It's been mandated by the safety team that every employee watch a video on how to don and remove PPE properly. It was a biosafety measure by the entire hospital team. Our hospital gave us all scrubs that are laundered by them, and we have dedicated shoes. And we wear hospital-grade masks at all times. We are conserving our N95 masks for Rhoads and cytopreparation procedures. It's appropriate to wear the surgical mask during the day, but you only need to use the N95s on site. What we do is we take the N95, and over that, we place a hospital-grade mask. That is so that we can utilize the, reuse the mask. Per person. It's not shared amongst each other, but per person they can use it for a couple days as long as it's not soiled. So the surgical grade mask goes over the 95 mask to make sure that it's protected, and over that we cover it with a full face shield. And I bring that up because everybody's so focused in the community on masks, and as we should be, but you can't forget your eyes and touching your eyes and transmission of eyes, and that is the importance of face shield and face goggles. We use disposable contact isolation long sleeve gowns and gloves, and proper hand washing techniques are extremely important. Hand washing is probably the best way to remove the virus from your hands. very early onset, we made sure that compliance was occurring. And again, we're very fortunate that we never suffered any shortage of PPE. Next slide, please. Our Rhoads procedures, cytotechnologists only are going on these procedures, and we're transmitting images by telepathology to the cytopathologists. Again, we've decided to use universal precautions. The seriousness of catching this illness is too much to take that risk. So we use full PPE while we assist on these procedures. Again, radiology, intervention radiology has dedicated a specific site, which is very helpful. They even created an interesting shielding anteroom next to their site. So it's a little bit easier for containing and cleaning. Interestingly, in our outpatient clinics, which we had only a few processes, but they also checked our temperature in addition as the patients before we were allowed to assist on the procedure. We make sure that we cover a bigger surface area with chucks and make sure the whole area is covered, a wider surface area in case there's any spill. We do not use a fan or wave the slide in the air to dry before we do our diff quick stain. Rather, we lay the wet slide on the countertop to dry as much as possible. In our one dedicated area, we do have a plastic type of hood. It's not a biosafety hood, but it's at least some protection to the environment. We have experimented with different various techniques of one of the suggestions from our technologist was to use those hand warmers, those gel hand warmers that you put in your mittens for the winter time. So we've tried to put the slides on there to see if it will wrap it fast, but basically with this whole pandemic, we've had to learn to have a little bit of patience and waiting a little bit longer for the slides to dry. We have to make sure that safety is of utmost importance, and the fan and waving the slide and dry is not safe. Probably the biggest challenge on Rhoads assessment is when you have your 95 and you have the face shield over your 95, it's very challenging to look through traditionally through the oculars on the microscope. So what we've had to transition to, because the face shield creates a limited point of view. So what we do is we scan the slide on the microscope and we view the screen that's transmitted to the pathologist in order to make our adequacy on site. Again, everything at the end is placed in a biohazard bag. We disinfect the entire workstation, remove our PPE and hand wash on site. And when we get back to the laboratory, we hand wash again. A lot of hand washing. Next slide. The economic impact, as you all know, in the nation has been very huge. As you can see on the right-hand side, this is a picture of Grand Central Terminal. This is during rush hour at 5 p.m. one day. And you can see there's like 2 people in the entire Grand Central. So the amount of New York City shutting down is just, it's really unprecedented and remarkable. As in your institutions, I'm sure procedures were greatly reduced. We worked hard to stagger employee shifts. We deployed where we could. And again, I can't thank our New York Presbyterian system enough. As yet, we have not suffered any pay cuts or furloughs. In fact, they did give us a small bonus of pay for risking and coming into work every day during this challenging period. Since we have not lost our cuts or furloughed, I would say that a lot of our staff have family members have suffered from unemployment and loss of jobs, and that of course impacts them as well. Next slide. Going forward, I'm very grateful that we have enough PPE at this time, but as numbers increase in the nation and our volumes return, we'll have to make sure that the supplies are available. And with the note of supplies, we've just recently had some issues with getting some stains and some materials and reagents. And I'm, COVID has affected the delivery. It's affected the manufacturing of items. So the impact in those areas we're going to have to transition as problems adjust, and just to be aware of those might be potential issues down the line. We haven't had that many complaints because we don't wear full PPE for long periods of time, but this is something that you'll have to be aware of with certain staff members. Again, we're just going to keep being flexible and adjusting as things happen. Social distancing, and employee travel to a workplace. We're in New York City, so a lot of people have to travel on busy subways and transportation, and the transportation doesn't run so smoothly. So those are challenges. And of course, the most important thing is staying physically and emotionally healthy. Next slide, please. Some of the questions I was asked to respond on was, the first one was, how do we keep communications open? Very early on, I updated our emergency contact list. You should all have one just in case you need to communicate off-site, and update that regularly. We do email and Zoom meetings as everyone, and I just want to take a moment to thank the ASC for the unbelievably fabulous webinars that we were able to participate in for continuing education during this time. I think it really shows the support of the society for our profession. And I mentioned before, we do telepathology for communication, and we use mobile heartbeat devices for our Rhoads assessments. And myself personally, I came in most of the, during this period, I came in most of the time, and I face-to-face did small social distancing team huddles and frequent rounder. As the leader of the cytology department, I felt it was important. You can't do everything on Zoom, and face-to-face is very reassuring, and making sure that you're watching procedures and really saying what happens to make changes. Next slide. Did I have any potential negative personal experience due to the pandemic? So in New York City, again, our numbers are huge and everybody's been impacted. And if you haven't been impacted, you know somebody personally who has from this pandemic. We have lost some staff over the Presbyterian Hospital. A lot of the employees were frontline workers. And this, of course, is upsetting and very sad for most of us. Personally, I did lose my mother recently. I was not able to travel to see her before her passing or be with her at the end, nor was I allowed to have a proper memorial service with my family during that time. Next slide, please. Oh, next slide. Has myself or anyone experienced a negative psychological effects such as stress, and what do we use to combat these? So again, I can't thank our Presbyterian organization enough. Every day, our COO and CEO had daily information leadership meetings. These are online for everyone in the entire organization to see. And not only were they very upfront and gave us numbers and statistics about what was going on in the hospital, they provided a lot of leadership moral support. Every day, they also reiterated about PPE education and where can we get supplies and if we had any issues. And importantly, they provided many, many support services. They went above and beyond. They gave us extra support services for medical care, child care, transportation, housing, meals, and also emotional well-being, counseling, and areas to go. And uniquely enough, at our institution, they dedicated relaxation and quiet rooms. There's a yoga mat and a nice chair in there, and you can sit and watch some pretty relaxing tapes and have some quiet time if you need to just have some space. We all do breathing exercises, mindful meditations or help, but one easy thing to do, and you don't want to underestimate, is a 15-minute outside walk, fresh air, fresh sunshine. It does absolute wonders, and it's important for sleep, I think, also. And most importantly is listening and having empathy to your team members, and we're all in this together. It's very challenging, and if we acknowledge it and we're able to talk to one each other and support each other, which I think we've seen in the survey, those areas are the best for reducing stress. Next slide. Going forward, are there any positive experiences? So these flowers over here are flowers that I actually saw on one of my 15-minute walks. I attribute the beauty of the flowers in New York City, partly to our cold spring, but partly because there was a lot less pollution, a lot more oxygen, and I think our wildlife and everything is benefiting from that. So I think positive experiences are safer workspaces, cleaner environment, and of course, gratitude for everything personally that I have in my life and my team. And I think our team has gotten closer and stronger as a result of this, and we've met the challenge, and I would like to continue that in the future. Next slide. Thank you very much. And I just want to end with, this was another nice touch of Presbyterian had. These little sidewalk messages as we come in and out of the building. Early on when the stress was a little high, you'd come out and you'd see these little notes of thank you and moral support. And it was just such a nice touch that everybody just sort of lifted their spirits. So thank you very much, and questions will be at the end of the presentation.
Thank you very much, Susan. Thank you for sharing your experiences. I'm sure there's going to be a lot of questions, and we are sorry for your loss also. Next up was actually going to be Dr. Maureen Zakowski, who recently got her JD from the Fordham University School of Law. And she's a well-seasoned cytopathologist who's in the East Coast. I think we're having some technical difficulties and conflict there, but a couple of the pictures that she sent to us is that they transformed the entrance of the hospital into some sort of a mobile unit, and they added like little patients' rooms. Maureen, are you on? Okay. And then she was just showing all these and that they're all in masks. And of course, you know, the lovely hashtags from coming from New York, the New York strong and New York tough. And some of us even have dropped or developed some crush for the New York Governor Cuomo, the Cuomo crush. If we are able to reach Maureen, we will add her at the end of the panel.
The COVID-19 seminar of people from Seattle, as well as, what did I do, mute them?
I think you want to be muted, whoever you are, because our next speaker is going to be Dr. Ghofrani from Seattle area, from Vancouver, Washington, and he's going to be talking about the West Coast experience.
So it looks like, oh, can you hear me? Okay.
Yeah.
Thank you, girlies. Thank you, Stefan, for moderating this session, and thank you to all the panelists. I will try to be quick. I'm going to be wearing 3 hats during my part of the presentation. One, I'm going to explain our experience here up in the Pacific Northwest, how we dealt with the pandemic. Then I'll also touch upon a little bit on the business aspects of the pathology practice. And finally, some comments on what the American Board of Pathology has been trying to do to accommodate its diplomates and applicants for the exams. So just so that you know the context, we are a regional healthcare system in the Pacific Northwest, and we cover 10 large and small hospitals and multiple clinics, mostly in suburban and rural areas of Oregon, Washington, and Alaska. And you probably remember that the first case in the US was identified in Washington on January 21st. This was a person who had traveled to Wuhan and upon return was diagnosed with COVID-19. Early on in the pandemic, the West Coast states, Washington, Oregon, California, they implemented social distancing and stay-at-home orders very early and very widely. So I don't know, maybe that might be one reason, Stefan, to the survey, which mentioned that there was more stress in the West Coast, but I'll defer to Tim on the more educated guess. So since we were early on in this pandemic, we are currently on the downslope of the first wave. And so I think we can look back and evaluate how we performed during this crisis. Early in March, in our system, an incident command was set up with involvement from senior leadership down to all the people in the trenches. And I remember I was called in on a weekend to our system office to be providing lab support and lab input. And I think that's one of the silver linings that I observed in this pandemic was that how we as a large system responded very rapidly and very inclusively, having representatives from all different levels and all different departments of our healthcare system. We had several virtual meetings with sometimes over hundreds of participants across all of our networks, 7 days a week. So there was this constant communication, and frequently, at least daily, there were email communications going to all our caregivers to update them on the processes and the status updates, because the situation was so fluid in those early weeks. In terms of securing lab testing, we had to improvise a lot because, as you remember, initially there was a lot of limitation in testing availability. There still is. Initially, CDC, and then following by that, the state public health labs were the only labs that doing the testing, but they soon got overwhelmed. We have been partnering with a national corporate lab for our testing, and so we were thinking that they would be the best, most assured option, because we were expecting that they would be able to scale up rapidly and meet our needs. Unfortunately, since they were a national lab, they were accepting specimens from all across the country, and so they soon got overwhelmed, and our samples were being sent to them, were being resulted with a very long turnaround time of over a week and 10 days and sometimes. So that was very unacceptable, and we had to diversify our lab testing. So we, depending on the logistics of the particular location where the sample was going from, we would send it to the state public health lab across the 3 states that we cover, the corporate lab, and especially as time went on, one of our local commercial laboratories, a private lab, stepped up their offerings of testing up to a few thousand a day, and that was really helpful to us. So that just goes to show the importance of having these partnerships with commercial laboratories. But as I said, I mean, the send out in the best case scenario had several hour turnaround time, if not days. And so we were treating all our patients as potential COVID-19 patients and using up precious PPE and isolation resources while we were waiting for those PCR results. So we needed a rapid alternative to make isolation decisions and optimize our PPE use. And so we brought in the point of care test, and you've all probably heard that there are concerns with lower sensitivity. So we fine-tuned our approach as to how to use the point of care. So we were only using it in asymptomatic patients. So this is a low pretest probability group, and if you use a lower sensitivity test in this group, you minimize the number of false negatives that you're going to get. So we made it very clear, and we set these guidelines within our system that if you have a patient who is symptomatic, who is suspect for having COVID-19, do not use the point of care and do PCR testing instead. So the moral of the story, I think, is that even though lean principles recommend that you standardize, and under normal conditions, we would try to go with one vendor and one test platform, but these are not normal times. And so we have tried to not put all our eggs in one basket, and we've been trying to diversify our testing strategy. Of course, this is going to create some IT challenges because now you have to create order codes for multiple types of tests. You need to format the results and make sure that they're all according to the mandated formatting and information content that needs to be in the report. You need to create analytic reports for infection prevention and ID, monitor your testing volumes, your turnaround times, and see if there are any trends that are going to require any changes. And also, you have to decide on a case-by-case basis if you want these tests that are being sent out to be the results coming back in through an interface, or if you want to enter them manually, depending on the volume of results that you can be coming in. And I'm sure all of you also had the same situation, that it's not just a matter of having the tests and having the reagents, but simple things like the swabs or the transport media or the tubes were also a challenge. And so this goes to show the importance of some elements in any healthcare system that you usually don't think about, like supply chain, how important they are for us to be able to continue providing care to our patients. And in terms of its impact on cytology specifically, Susan, what they've been doing, and we have been taking the same precautions. Obviously, a lot of elective procedures, all elective procedures, so our volumes had gone down. FNAs that cytotechs were assisting on dropped. E-buses were still happening, and initially when we didn't have wide access to testing, all patients were treated as potentially COVID. So for any aerosol generating procedures, we were using N95s and the whole 9 yards. Now that we are testing all our patients coming into the hospital, we are using surgical masks and the rest of the PPE for patients who have tested negative and are there's a fair assurance that they are not going to be spreading COVID. In terms of setup prep, once again, if there are aerosol generating procedures, we're using N95s, face shields, and we have engineering precautions in place like working under the hood. So I'll shift gears now and talk a little bit about the impact that this has had on the business of pathology. And I'm sure that we will be able to make a better assessment of this after this is all said and done. But obviously, there has been a significant drop in non-COVID testing. And analysts early on had predicted that there would be at least a 35% drop in lab testing. That turns out to have been a very optimistic and best case scenario option. Personally, here in our department for pathology, we've experienced about a 2/3 loss of our pathology volume. And the reasons are varied. I think the most important ones are obviously cancellation of the non-urgent or non-emergent procedures, but also reluctance of patients to seek healthcare, not only for the non-essential visits, but even if they really do need care, like management of chronic conditions. Or some issues that they would normally go to the ER, but now they just write it out. And this may be due to fear of getting infected with SARS-CoV-2, or they may have suffered a job loss or a decrease in their income. They may have lost their insurance. And so there are all these financial considerations that are at play that may be leading to this decrease. And obviously, this has led to some layoffs, even in our industry, in the medical and health industry as well. But it looks like that most of the industry layoffs and furloughs are happening on the administrative side of the business, as labs are trying to maintain their clinical staff as much as possible. Now, with this decrease in revenue, some labs are trying to move into COVID-19 testing to help address the broader shortfall. But I really doubt that you're going to be able to make up for that lost volume with just COVID testing. But even if labs do decide to go this route, it can be difficult if they don't have the instrumentation and if they want to make a capital investment to purchase those instruments. And especially even if they do make a capital investment, there might be limited reagent supply, and that would limit them from using their instruments at full capacity. And so basically, they would not be able to totally recoup their investment. And there's also the issue of lower reimbursement for testing. So labs that do decide to go this route will need to be really lean and efficient to be able to cover their lab costs. So with that, I'll put on my third hat, which is my role as the trustee of the American Board of Pathology and what the board has been trying to do to give some assurances to our diplomates and our applicants. So as you probably know, for the fall 2020 primary certification exam, we had to make the difficult decision to cancel the spring exam. So anyone who has registered for the spring exam has been automatically registered for the fall examination. And if they have to cancel, then obviously they can contact the board and get a refund of their application fees. And so the question that came up was, how are the board exams going to be given? I think it would be good to answer a question before I answer this question of how the board exams are going to be given in Tampa by answering the question, well, why don't we do the exams remotely? The reason that we can't use commercial testing centers to administer the AB Path exams remotely is that, as you all know, we still use glass slides, which needs a microscope. And then even for the virtual microscopy questions, the exam centers, the commercial testing centers, would need to pay a software license fee. And with the number of centers that exist around the country, that would be very cost prohibitive. And so those testing centers have not agreed to do that. And even for the clinical pathology exam, we've previously had discussions with commercial testing centers, and they can't guarantee that the quality and the resolution of their computer monitors is going to be sufficient, because even the clinical pathology questions, many of them do use images and they need to be displayed on high quality monitors. And so, yes, we have done remote testing for continuing certification exams, but that's different from the primary certification because they're not considered as a high stakes an exam as the primary certification is. And there's a risk that the board has deemed that's unacceptable in terms of security of the questions. So with that being said, now that I'm hoping I've been able to convince you the reasons of why we need to continue to administer the test in Tampa, we have made changes for the fall administration of the exam to accommodate some, even if they're still not mandated in the fall. So we are going to be administering with the 6-foot social distancing in the exam center. Only 35 candidates will be seated in the exam center each day in every other cubicle to maintain the distancing. And since we're going to be operating at a lower capacity for the fall exam, we've expanded the time period where the test is going to be administered from October 5th, 1 week earlier than what was previously posted. And the anticipation is that the last day of the exams will be November 14th. And these dates will include administering the exam on weekends, so we can make the most use of this time period. The subspecialty exams have also been extended so that we can accommodate all the candidates at a safe distance. And if any candidate wants to cancel this, if this time's scheduling will not work for them for coronavirus concerns or any other reasons that you can't attend, then you can cancel and receive a full refund of the exam fee. You just need to notify the board by email before the exam date. And this year, one other accommodation that we've made is that if you are taking a primary exam and a subspecialty exam this year, we've made an exception so that you can take your subspecialty exam first and then take your primary exam after that. The only thing that we will do is that we will have to withhold the subspecialty results until the applicant has passed the primary certification, and then both results will be released. Other accommodations, in terms of continuing certification requirements, we have extended the deadlines for reporting those continuing certification without penalty. We don't want anyone to be losing their certification or be penalized because of the hectic times that we're in. So we are very supportive of our candidates, and we feel their pain because we're all in this together. The participation requirement for CertLink, as you know, that's the longitudinal assessment that the American Board of Pathology provides. And I'd like to give you the good news. It's not official yet, but this will be soon replacing the 10-year recertification exam. But we've waived the first 2 quarters of 2020 as a requirement. So if for any reason, for the first 2 quarters of 2020, you cannot participate in CertLink, that requirement is waived. We're also likely to relax some of the autopsy numerical requirements for 2021 for the AP and forensic pathology candidates, but this hasn't been decided yet, but that's something that we're thinking of. One question that I received was, what is the expected impact of the lockdown on the training and knowledge of residents and especially fellows? We're hoping that it's not going to be a significant impact, and we have given program directors great latitude in how they're dealing with teaching of their residents and fellows. The AB path will allow for absence from on-site training for any COVID-related reasons, and that will still count as clinical training if the resident or fellow arranges with their program director to continue learning and training activities. You'll just need to keep a daily log of the time spent and the brief description of the activity that was happening if it wasn't on site. And also the program director, as always, is going to attest to the overall competency of the resident and fellow at the completion of training to make sure that it was not adversely affected by the absence. And the AB path is always open to hearing suggestions and recommendations, and if there are any additional requests for absences, these will be addressed on a case-by-case basis. So with that, I'll be available for any questions that are during the Q&A session. Thank you.
Thank you very much, Mohi. That was, wow, 3 hats. That's amazing. I believe we have Dr. Zakowski on with us right now, so I'm going to go back to her slides. Maureen, are you there? Can you hear me? Let's see. Let us make sure that everybody is there. Can you hear me, Maureen? Nope. Let me just quickly see. 1 second. I can hear you. I can see you, Maureen, but I can't hear you.
Maybe we can go to Timothy Bono in between and try to
Actually,
hear
we have
about happiness and then go to Maureen after she's set up.
actually, okay, let's do that. Give me a minute. Actually, the next step is going to be our telepathology informatics expert, Dr. Pantanowitz. You're up.
Right. Hi, everyone. Thank you, Dr. Belize and Dr. Pambuccian for inviting me onto this panel. And hi, everyone. And, I hope we're all making it through this COVID crisis. So I'm going to be talking primarily about digital pathology and specifically telecytology. And we'll share our personal experience at UPMC in Pittsburgh. It was mentioned already that in anatomical pathology, volumes dropped down a lot for specimens, and that was true for cytology, mostly for PAPs and certain non-GYN samples like urine. But what we did notice was that our F&A volume did not fall that much, and so as a result, the demand for Rhoads, persisted. That meant we had to safely provide a Rhoads service, and we had to deal with certain staffing issues, such as shortages due to people working from home, which I'll get into shortly. As a result of the need to provide Rhoads during the time of COVID, we had to resort to telepathology to support the cytology service. Fortunately, at our institution, we have a telecytology system, and we have 2 systems in place, which were validated and in use. And the 2 systems were set up based on cytotechnologist availability on site. So if a cytotechnologist could go on site, We could have video streaming because the cytotech could make the slide and show the slide to a cytopathologist remotely located. We use an RMT system for that, which is high definition video streaming. If, however, a cytotechnologist cannot go on site, and we have a facility like that, which is our children's hospital, although a slide can be made by a histotech, even radiology staff, for example, there is no cytotech to drive that slide on a microscope. So in that case, we use robotic microscopy. We use a Perio's LV1 scanner for that. That allows the cytopathologist then to take control of the slide, navigate, change magnification, and focus. So fortunately, as I'd mentioned, we had both of those systems in place and validated. When the COVID pandemic came around, the need then arose for us to extend the remote location of pathologists. Could they work from home? I would like to thank our cytotechs at this time at my institution who continue to go on site. We provided them with PPE to do that, and they were on the front line preparing slides for us for Rhoads so that pathologists could work remotely. Initially, it was frustrating because we could not work from home because of CLIA. As all of us who live with CLIA 88 know, there are many rules and regulations, but one of those CLIA rules is that you have to work within a CLIA environment, which is really within the lab that holds the primary CLIA license. With a lot of lobbying and through the action of societies like CAP, associations like DPA, etc. Eventually, March 26, CMS provided a waiver for CLIA, which meant that we could work from home. You could work from home digitally, but if you wanted to, cytotech could also take their microscope and screen cases from home. So as a result, we were able to allow pathologists, if they chose to do so, to work from home to support the Rhoads telecytology service. Now, before we could do that, and I would recommend for those of you who want to do that, you need to extend your validation to the home environment. We, not really thinking a pandemic would ever come around, but when we validated our telecytology setup, we made sure that we didn't tether the pathologist to their office. We wanted to make sure that the pathologist could be remotely located anywhere. So our validation included, working with an iPad and an iPhone. And so it didn't matter which monitor the pathologist was using. We did this because pathologists were required to go to meetings, lecture, attend the FNA clinic, etc. So that made it easy to extend this to home. The next thing, I also wouldn't advise telecytology for the novice. You really have to be experienced and competent. And so if you are going to allow someone to work from home, they have to be trained. Training in a rush instance is stressful, but fortunately, we had competent cytopathologists who were able to do this. Just like we do in anything else in cytology, you need a QA program. And so we had a QA program in place, and we haven't had to use it during this time of COVID. But the QA would be, you need to be able to make sure that you're documenting IT problems and that they get fixed real time. You need to document problems with the cytotech on site, and you need to document problems with the pathologist. If they're overcalling, undercalling, deferring too much, that has to be addressed. IT support, obviously, is extremely important in this case. And there are lots of things that are out of control for your IT team. For us, public networks, for example, what computers and monitors people have at home. The one thing I did make sure we were addressed was I contacted our department's administration to make sure our cytopathologists and pathologists that chose to work from home were covered from a malpractice perspective in event something went wrong. Now, we also have a whole slide imaging system set up, and unfortunately at this point, the whole slide scanners are not designed for cytology primary diagnosis because we don't scan in multiple planes and they're difficult to navigate. Our whole slide imaging system is set up such that it's integrated with the lab information system, and it is there for primary diagnosis of surgical pathology, and it was validated for pathologists who work from home, and we had a few pathologists signing out cases, and we still do from home now. For the cytopathology division, what we did was we allowed whole site imaging to be performed for second reads. So, for all of you who practice cytopathology, you know that curbside opinion or even a formal second opinion is very helpful for challenging cases. And since we didn't have people in the office at the same time, they still had challenging cases or needed a consensus, for example, and we used whole site imaging for that purpose. Now, by providing people digital pathology tools to do this, the benefit was we were able to provide continuity of care. Second, we were able to address staffing shortages. Fortunately, we were not aware of anyone in the cytology lab that got COVID and had to have forced quarantine. But we did have people who adhered to, sheltering at home. We had some folks who, their kids' schools were closed. They couldn't get childcare, so they were forced to work from home. And we had pathologists who would like to minimize their exposure and not come into the hospital. Now, having done this, there were certain IT issues that we encountered that you may encounter. Number one is bandwidth. We are relying on a public network to perform digital pathology. And as Dr. Monaco had informed me, when she was at home performing telecytology for Rhoads, she had a physician her husband was a physician doing telemedicine, and 3 kids trying to use Zoom to do virtual schooling. And so, that completely takes up the bandwidth, right? So that's an issue that's kind of out of our control. Just because you're practicing telecytology doesn't mean you have to practice bad cytology. And so, HIPAA compliance is still important. And so we're not recommending Skype or anything like that. You need to make sure, as we did, that our IT group, will allow us to use applications and products that are HIPAA compliant. But we also need something that's easy for people to use. It's not that easy because I will be honest with you, many of the tools that are available today have been designed by the vendors to work in a hospital environment on a workstation that has that's within your firewall. But now when we're asking people to work outside the firewall, there are lots of passwords to log into, navigating these things on computers or monitors that are not hospital issued or medical grade becomes challenging. And so if there are any vendors listening on this call or on our panel, I would ask you, if there's one thing you should learn from the COVID epidemic is make your product web friendly, because I don't know how long this will be around and how long we would have to work this way, but they shouldn't just work in a hospital environment. When we were doing this, there were certain challenges to workflow. Challenge number one was, many people were afraid of making air-dried smears on site. And so the recommendation was don't make air-dried smears at the risk of aerosolization. And rather, if you're doing rows, do rapid alcohol fixation. And then you could still do a diff quick or modified PAP if you wanted. So we made that switch based on the recommendation. And I'd like to thank the ASC listserv for being available so that, we could chat and do that. But I don't know if any of you have done that, but when you do an alcohol fix on site, the stain's very dark. And for those of you who do telecytology, even though you may have a great high definition setup, it's usually a little darker. So you confound a darker image together with a darker stain makes it very difficult sometimes to figure out if you're dealing with small cell carcinoma versus lymphoma on a laptop or an iPad. So that is challenging, but we've managed that. The next thing is you'll be surprised, even if you're digital, you're still dependent on paper. And we still have some dependency on paper. For example, when you do a rose, the cytopathologist has to document, what their interpretation is, or if they want to order immunostains or upfront, for example. So we had a challenge where the paperwork normally handled by our cytopathologists, that burden had to be shifted to our cytotechs. So again, I hope our cytotechs are listening, and I want to thank them for stepping up and doing that. And when you go virtual, it's not just the image that has to be virtual, it's the communication. So you have to be able to talk to your cytotechs on site. And you also need to be able to talk to the proceduralist, the thoracic surgeon who's doing an EVIS, or the radiologist. And so we had set up a Bluetooth speaker in each location as well as F&A cards. So our cytotex iPhones automatically connect to the Bluetooth. And that way, the cytopathologist is virtually connected through communication with anyone in the room, which was very helpful. And so I think at this point, it's been a win-win. We've been able to do this. We've been able to provide a Rhoads service, and we've been able to permit cytopathologists to work from home without any major issues. And so to conclude, basically, my my talk is, what does this mean for us post-COVID? Because will we all, now that we've demonstrated telecytology and telework in general, as mentioned for teleeducation, teleconsensus conferences, etc., should we go back to the old way if we've demonstrated that this is feasible? I think it's important for those of you who are doing this telecytology to please document this. This is what is considered real-world data. And this real-world data should be collected and published. And the reason I'm saying that is because the FDA needs to see that. Because many times we're restricted. CLIA has restricted us from now. FDA clearances of these technology products has restricted their use. But since these were laxed and we got these waivers during the time of COVID, and we were able to do this without very expensive lockdown systems, when the FDA see that, it may be much easier for vendors in the future to get FDA clearances or approvals, or even CLIA to allow us to remotely work with data outside the lab environment. And that will just make our lives easier, bring down the cost, and benefit patients. So I think that's a silver lining from the COVID pandemic from a technology perspective. At this point, I'm going to hand on over back to Dr. Barkin and Pambuccian.
Right. You didn't want to show your wonderful pictures while you were doing, or Sarah was doing rapid on-site from home?
Yeah. I didn't want to have too many PowerPoint slides, but here's a PowerPoint slide. That's Dr. Monaco's home telecytology office. She was able to do telecytology at home. What you cannot see is the 3 kids in the background working with her. And then the next slide is, Gilise asked if we do this in our pajamas. So you can turn Rhoads into relaxed on-site evaluation. Because, you can do this at home in your pajamas, with a glass of wine if you choose.
Oh, rub it in, Liron. Rub it in. All right. Maureen, are you on? Can you hear us okay? Yes? Having some technical issues maybe still? Can we hear your voice if you're there? If not, we'll push you to the very end.
Can you hear me?
Yes. Okay, we can hear you now. I'll go back to your slides. Here you go. You're on.
Emergency. But I'm here now. So,
Maureen, you have to pick your phone up. We can't hear you.
Can you hear me now?
Yes, we can hear you now. Yes.
Sorry that my technology isn't working well, and I do apologize again. I would never try to jeopardize this wonderful conference, but we did have an emergency. So if everybody's ready, I'll be happy to tell you a little bit about my East Coast experience. Okay, ready? I can hear someone talking in the background. At this hospital where I work, we were mandated to increase our bed capacity by 50%. That was a New York State government regulation. And if we go to the next slide, you will see some of what was happening. The lobbies of the hospital were turned into hospital rooms. And you can see them in construction here, and you can see the equipment that was brought in. This was a bit unnerving for our people, and it also resulted in different patterns. We were not able to use certain corridors for transit. It rearranged where we brought our Rhoads carts. It made it difficult for the pathologists to get to the cytotechnologists. So that was a little bit of a physical problem. In addition, our hospital is right across the street from Central Park. Central Park itself was turned into a hospital, kind of looking like a Civil War field hospital, and that blocked the traffic and the buses. Many of our cytotechnologists and our ancillary personnel travel by public transportation. The ridership and the routes of public transportation were down about 90%. So that increased the difficulty of people even getting to work. Our department decided that we would not be able to work from home, that we had to come in every day, and that our presence was absolutely required, no questions asked. I don't know whether that resulted in infections or not. I do know that 3 cytopathologists here, as well as 1 fellow, contracted COVID, including myself, and that made it difficult. The number of specimens that we have fell greatly, and while we normally put 2 pathologists on a day to sign up the material, I reduced that down to 1 a day, and we kind of, and I never said this, unofficially changed our schedules to keep people from public transportation and from coming in every day. New York City is largely a public transportation place. Very few people drive to work at the hospital. We dealt with some cytotech issues of people being out sick, but more interestingly for us to manage their families being sick. So they were not able to get COVID coverage or time off because it was their family that was sick without taking unpaid leave. So we had some of those kinds of difficulties that I think that everyone else experienced. We made some changes in the way we operate our cytology lab. We went to a very increased sanitizing, sterilizing procedure for our equipment. We upped the amount of alcohol that we used in the collecting media for our specimens. We did not suffer from a loss of personal protective equipment. Initially, our equipment was stolen from a closet in cytology. I don't know how that happened, but that happened. Once that was replaced and things were well secured, we no longer had problems getting appropriate equipment. So we didn't have any problems with that. We maintained a service to aspirate patients, some of whom had COVID. We had N95 masks for the aspirators and for the patients. We did ask that our specimens, for example, the BALs, the bronchial washes, the EBISs, everything be fixed. So we don't see smears right now. We're not seeing smears of EBISs. They're all put into fixative, and we're looking at them on Cytolite. And that's a little bit different because some of the personnel were not as familiar with looking at it in that way. We had some problems with the desire to deploy personnel to other divisions. So, for example, we had one person who was deployed to move boxes in the pharmacy. I found that that to be very difficult to get our work done. And for the morale, our particular issue was bronchoscopy. This is a hospital that serves a largely economically depressed community, which, as we know, is more stricken with this virus. And so we had many bronchoscopy procedures to deal with. And we had to assure that we could keep our people safe. And the idea of, because our numbers were down, that our personnel should be deployed was difficult to handle because we don't know, we couldn't predict when someone was going to need to have the assistance at a procedure. So I greatly fought transferring people based on numbers. If someone needs to have an adequacy assessment, we had to have someone make that adequacy assessment, whether it was 1 a day or 100 a day. So that was a little bit of an administrative struggle. We tried signing out remotely. We had some difficulties. This is a large residency program where we have residents in the same program that are stationed at 3 different hospitals with 3 different, quotes, residency directors. One residency director refused to allow the residents to become involved in any procedures, which was difficult for me because I don't see the cytotechs as less valuable than a resident, but yet they were put on the front lines and there was no backup available from residents. That was something we had to deal with. We tried signing out by me looking at my slides with the camera that's on my scope, putting that on my computer, and then sharing my computer screen to the fellows and the residents at a distant site and to the cytotechs to some degree, although most of our cytotechs were off on procedures. Nobody really liked it, although it technically worked. It eliminated the one-to-one instruction experience that we come to rely on. You know, we look at each other's facial expressions. I can tell if someone understands what I'm saying or doesn't understand what I'm saying. And so I stopped doing that, and I just sort of meticulously scrubbed down the multi-scope area before I went there, after I went there, washed the seats that we used, the armrests, etc. I felt that there was a value in being with people. Now, we still wore masks and gloves, we still do, that kind of thing. The cytotechs don't sit with us now to sign out. That's been changed to have fewer people at the scope, although our physical environment is such that it's difficult at best for all the cytotechs to sit around the scope. We had challenges in that area. We did not feel unsafe. There were many, many conferences, many impromptu sessions that I held with the cytotechs to reassure them. And in fact, I know of no one who became infected from a procedure, during a procedure, or handling any materials under hoods, which is what we used, or using slides. As I said, 3 cytopathologists did become ill, but it's difficult to pinpoint where that happened. There was a great deal of anxiety in the laboratory that we dealt with, a great deal of cytotech anxiety. I personally kind of focused a little bit on the psychological aspects because the team is so very important to me. I wasn't so worried about the infectious part because I thought we had that under pretty good control. As I mentioned, we do serve a depressed community, and we're very familiar with TB here, with pneumocystis here. So our precaution level on handling specimens didn't change that much. But I did feel that the cytotechs needed an extra amount of support just to get them and their families through this. And we're not through it. We have stopped using the lobby beds, but we're certainly not through this. We've noticed this week that our specimen amount, the number of specimens is rising. And so it's more important than ever for us to keep our cytotechs. One of the problems that I had this morning was they wanted to furlough one of our cytotechs because of numbers. And that was a very difficult thing to explain to administration. But I have to say that the vast majority of our problems have not been in the realm of infectious disease, nor have they been in the realm of remote sign-out. As was pointed out, cytology is not well suited to digitization, and we have a very fast turnaround time here. So we really can't wait to have someone scan our slides, et cetera, to wait to sign out. In fact, sometimes we just sign them out within hours of receiving them, and that's what we've been doing now. I'm very happy to address any particular issues about COVID. We have a very, very talented crew, and we have well-trained cytotechs, and our current manager is been very supportive in what we need to do. It's been difficult, as it has been difficult for all of you. But again, our difficulties were really not in the realm of equipment or fear. Our difficulties surrounded, for some reason, psychological issues. And I don't know if that's something other people experienced. We did curtail our CME. We don't offer any sessions for our cytotechs right now. We used to have weekly cytotech pathology sessions. What I have been doing instead is sending them PowerPoints that I've made up on particular issues to look at their own time, at their own desks. I don't know what this is going to do to the mandated number of educational hours that cytotechs need, but we certainly have curtailed all of that for the time being. I don't think anything else that we do is particular. Our patient numbers are very high here because we do service all of the cytology for 5 sites. The numbers have fallen in total, the numbers have fallen, but we still have to collect, transport, receive, and process specimens from 5 different sites. We have lost mostly GYNs and urines. They're starting to come back, but bronchs, we have lots and lots of bronchs, and we still have EBUS and transbronchials. So even though our volume is down, the hours that we put into it has not really changed. I was a bit late getting on, and I would like to know if you'd like to ask me any questions now, or if you'd like me to wait a little bit longer and address these questions at the end. I would like to make one comment though, and that is that I agree that we should be very careful in going to meetings. There is some thought that traveling to California for the USCAP was probably a risky thing with airplane travel, et cetera, and I think it's going to be a while before we feel comfortable sending our guys to meetings. We basically have our guys come to work and go home. And the hospital itself has started bringing in groceries and distributing them, I think, to keep people from having to go out, and also as a gesture of appreciation.
Well, thank you, Maureen. That's very nice insights coming from you as a patient, as a director, as a New Yorker, as a law student. It's very interesting to hear that. So
it may be different from the experience of other New Yorkers, but that's just how it's been in our particular setting. I don't mean to imply that this is the way every hospital handled it, but this is what worked for us.
Yeah. It's interesting that you say that psychological issues were one of the major problems, which is actually a very nice segue into our next speaker, Dr. Tim Bono, who's going to be talking about just this. Let's see if we can move on to his slides. All right, Dr. Bono, you're up.
All right, thank you very much, Dr. Barkan. If we could go ahead and advance to the next slide. So I am a faculty member in the Department of Psychology at Washington University, and the teaching and research I do focuses on predictors of well-being and happiness. So I was invited to draw a few ideas from my classes and from a book that I released recently that might offer some strategies for maintaining mental health given these harrowing circumstances that we've just heard outlined from our colleagues. So we can go to the next slide. In terms of our outline, there are really 2 primary things that I want to cover in the time that I have with you today. First is to provide some insight into a question that I've been getting a lot lately, given my teaching and research, which is, can we really be happy at a time like this, given all the challenges that we're facing? And then second, I want to shift to some strategies from psychology that we can incorporate into our daily routines to improve our sense of well-being and to take care of ourselves. So let's go to the next slide and take a look at that first one, the question of, can we really be happy at a time like this? To address this, I want to share with you 2 basic premises of positive psychology that I use on the very first day of my class when I teach this course each semester. Let's go to the next slide. The first of those is this idea that positive psychology is not about being happy all the time. And this is something that's really important to understand before we even begin talking about the strategies that increase happiness, because there are a lot of myths about the nature of happiness and its pursuit. And one of them is this idea that we're supposed to be happy all the time. Some people think that if they're not happy all the time, that means that something is wrong with them. But any psychologist will tell you that if you were happy all the time, that would be the indication that something were wrong with you. We humans have evolved this incredibly complex set of emotions, and there is a time and a place for each of them. And it's a natural, healthy response to experience sadness or anxiety when things aren't going well, or when we find ourselves in circumstances that aren't good for us. So part of psychological health involves understanding, number 1, that negativity is simply part of life. And then number 2, it's about having strategies that allow us to cope effectively with that negativity so that we can get back on that path toward well-being and happiness. So that's the first basic premise. We're not supposed to be happy all the time. If we can go to the next slide, the second basic premise is that positive psychology is not even about being happy. Instead, the goal really is to become happier. And some people look at that and they say, well, wait, what's the difference? Aren't those really one and the same? From my perspective, there is a world of difference between those two phrases. Because for us to go about our lives saying, gosh, I just want to be happy, or what do I need to do? What do I need to do to become happy? Or when will I be happy again? Those statements and those questions treat happiness as if it is a binary, a yes or a no, or 1 or a 0. It sort of treats happiness as if it is this destination off on the horizon. And as soon as I have the right job and the right salary, and as soon as my circumstances change, then I'll be happy. Well, it turns out that a much more useful approach toward the pursuit of happiness is to acknowledge that happiness itself resides on a continuum, because there will always be circumstances that are outside of our control that prevent us from being as happy as we want to be or as happy as we could be. But there usually are also behaviors and mindsets that we can incorporate that are within our control that allow us to at least become happier. And that's what the goal of the research in positive psychology is about. It's trying to identify those simple daily strategies that we can be applying in our daily lives to become happier, so that a year from now or a month from now, or perhaps even a week from now, we can shift our current mental state to be at least a little bit happier in a way that it sort of becomes a lifelong journey toward the pursuit of happiness and well-being. So let's think about then what some of those strategies are that we can do to become happier. Let's go to the next slide. And that's how I want to spend my remaining time with you, is to outline 4 simple strategies that I think we can all be thinking about to incorporate self-care into our daily routines. Because part of what makes this coronavirus situation so challenging is that it can very easily feel like things are spinning out of control. So it becomes very important then to focus on those things that are still in our control. And so again, I'd like to outline just some simple behaviors that can help us restore a sense of autonomy, and that also are well documented in the psychological research as being key contributors to our well-being. Let's go to the next slide. If we could go to the next slide, please. Thanks. So the first one is to practice gratitude. Certainly there are a lot of negative things going on in the world around us, but there are still many acts of kindness and generosity that are happening all throughout the world. And directing our attention to those good things can be very helpful in maintaining proper perspective while all these other bad things are happening. One of the ways that psychologists think about happiness is with a simple formula that says that we can consider it as the quotient of what we have as compared to what we want. And it's very easy for us to fixate, I should say, on the denominator of that formula, how we wish life could be different, or you log on to social media, you scroll through Facebook or Instagram, you see what everybody else has, and suddenly we want the lifestyle that they are leading, or we want to have the kind of luxury that they might be enjoying. And that is no good recipe for our happiness, because that is only inflating the denominator of that formula. If we could go to the next slide, one of my favorite quotes, is this from Teddy Roosevelt: "Comparison is the thief of joy." And among all the contributors of happiness, gratitude being among them, one of the biggest barriers to happiness is a sense of social comparison. So it's only natural that we pay attention to what's going on in other people's lives and very easily start to compare ourselves. But if we can catch ourselves in the act of that, and then redirect the focus of our attention instead to the numerator of that formula, to the things that we already have, that can go a long way in increasing our overall happiness. What's great about gratitude is that it's not actually about getting more things or getting a nicer car or a nicer home or getting more money. It's about focusing our attention on those things that we already have that we may have simply lost sight of. Certainly, we have to be giving some attention to what's not going well in the world and the important work that so many are doing to rectify that. But it's also important to maintain a certain sense of balance and perspective by also giving attention to those things that are going well. Let's move now to the next slide for our second of those strategies, which is to make progress toward goals. It's really important to have goals that we work toward each day that help us feel a sense of accomplishment. And it's okay to focus even on small goals, things like baking something or reading a few pages in a book that we've had on our bookshelf for a while, or going for a run, or even something as simple as making the bed. Very often, the satisfaction that comes from accomplishing even small tasks can motivate us to accomplish bigger tasks later in the day. And that sense of accomplishment proves to be especially important for our overall well-being. Let's go to the next one, number 3. And this is to take care of your physical health, because at the foundation of our psychological health is our physical health. We know that getting exercise on a regular basis is really important because physical activity triggers the release of neurotransmitters that can boost our mood, and it also puts the brakes on negative thinking cycles that are often characteristic of anxiety and depression. So we can follow the recommendations from the CDC in terms of how much exercise we should get 5 days a week. If we can get 30 minutes of moderate intensity aerobic activity, which is something as simple as going on a brisk walk, that provides those benefits both on a physical level and also on a psychological level. Our best research is showing us that you can break that up into increments as small as 10 minutes at a time. So if you can build in time to get exercise each day, even if it's just in 10-minute increments, that's great. If you finish a meeting or a project early, often the temptation is to check email or to scroll through our phones. But using that as an opportunity to go on a quick walk is a much better use of that time and can certainly give us a nice boost to our mental health. I appreciated the comment that my colleague Susan made earlier about the benefits of going on a walk, especially if it's a nice day, you can access to direct sunlight. That's a really good use of time. And often we will find ourselves in negative thinking cycles. Some of the neurotransmitters that the brain releases when we are engaged in physical activity are inhibitory, meaning that they help to put the brakes on those thoughts that can often be the precursor to anxiety or depression. And let's move now to the fourth and final of those, which is to prioritize physical distancing, not social distancing. There's been a lot of talk about social distancing, but I personally think that a much better phrase here is physical distancing. Certainly we want to keep a distance, but it's in times like these when it's more important than ever to maintain social connections with friends and family, whether that's through video chats or virtual happy hours or just a good old-fashioned phone call. That really is one of the most important ways to maintain our mental health, really at any time, but especially during a crisis. So if we could go to the next slide, just to kind of summarize what I'll call Tim's tips to become happier during a global crisis. Remember, the goal is not to be happy, but instead to be happier. So to the extent to which we can each day, we want to find something to be grateful for, even if it's just a small thing. Put attention on some good thing that we maybe have lost sight of. Number 2 is to make progress towards some goal, even if it's something small like making the bed or making a good, healthy breakfast. A really good goal is related to the third one, which is to get some physical exercise, do something to take care of yourself. That's good on a biological level in terms of the neurotransmitters that are being released, but also that sense of satisfaction that comes from having done something good for ourselves. And finally, and perhaps most importantly, is to reach out and to connect with someone. That is the single strongest predictor of well-being, and especially on a day when we're experiencing high levels of anxiety and stress, as we've heard all throughout the last hour and a half. This is a time when a lot of people are experiencing that. One of the benefits that comes from translating emotion into language is that when emotions are left to their own devices, they easily turn into those negative thinking cycles that can then lead to anxiety or depression. But the act of putting that into words often helps us adopt a more rational perspective that can be very helpful in sort of moving beyond that distress a bit more quickly versus it hijacking our psychological system. So I hope that this presentation and these strategies can be useful in helping us navigate these very trying times. And I'll also just put out there that these things are easier said than done. Inevitably, there will be days when we don't feel like exercising, or we don't feel like baking something, or we don't feel like arranging a virtual happy hour with our friends. And that's okay. On those days, practice self-compassion. Go easy on yourself. And to wrap up my remarks here, I want to share with you a quote. Since I'm broadcasting live from St. Louis, I thought I would finish with a quote from one of my favorite St. Louisans. If we could go to the next slide, please. There we go, from Maya Angelou, the great St. Louisan who once said, "Forgiveness is the greatest gift you can give yourself." And I really think that starts with self-forgiveness and self-compassion. On those days when we're not at our best, I think that self-forgiveness really is one of the most important gifts that we can give ourselves. And then when you can, turn attention back to making progress in those areas that are realistic for you. And so I'm happy to answer any questions during the Q&A, but certainly you've got my email, my Twitter handle, and information about my book. If you'd like to be in touch, please feel free to reach out with me directly now or at any time in the future. Thank you very much.
Thank you, Tim, and thank you to all our panelists. And now we are going to take some questions from the audience. And let's start with Susan. First, I would like to express my condolences, the condolences of the audience for the loss of your mother. And I would like to ask you one of the questions that the audience has asked about Rhoads and thyroid Rhoads especially. Do you recommend use of N95 masks during thyroid Rhoads?
Yes, we use N95s in all our procedures. We haven't had that many thyroids. Most of our procedures have been EBIS during this time, but we've gone on a couple lymph nodes. They're probably going to start up again. And I think because of the material, it's better to practice universal standard precautions with every Rhoads procedure at this time.
Thank you. Let me just ask the next question is for Liron, and it's about if the FDA procedures that have been relaxed are going to be continuing to be relaxed after this stops, and what we need to do to make that happen. And also they want to know about how many specimens did you use to validate? So more specifics on the validation.
Sure. So the FDA question first. I think everyone should be aware that the FDA does not regulate us in the lab. They regulate the manufacturers. I know we get caught up on, we should be using an FDA-approved scanner or an FDA-approved system. You can, but you don't have to, as long as you self-validate the system. They cannot market it to you. In other words, someone cannot come and say that you should be using this for primary diagnosis unless it is FDA cleared. We are regulated by CMS, and the deemed body to do that is through the CAP. So as long as you're compliant with CAP and CMS, you can use any system. And we do this all the time. Most of the immunostains and many of the other things we do are not FDA approved. I'm doing PD-L1 on many use cases that are not FDA cleared, but we self-validate them. So the same will apply here. In terms of validation, the CAP have published guidelines, but those guidelines pertain to whole slide imaging and not really for telecytology using robotic microscopy or streaming. So the magic number that is used in that CAP guideline is the number 60, and I would recommend you to use that number. The CAP did do a good job in looking at a meta-analysis with statistical validation of that number. Doing many more doesn't gain you much, and it's a lot more work. Doing less, you probably will not put that system through enough of a test use case to make sure that you don't catch any mistakes. Now, you don't have to do 60, and it becomes complicated. For example, at Maureen's site, if she mentioned she has 5 hospitals, if you want to do telecytology and cover 5 hospitals, 60 times 5 is a lot of work. So it's certainly reasonable at that point in time to cut that down. Maybe at one hospital you do 60, and then for all the others you do 20. And that's exactly what we did at UPMC. We didn't do, even in one facility, we have, say, 8 cameras. All the different suites on the F&A carts, 60 times multiple cameras is just too much work. So I would recommend, Stefan, whoever asked that question, try and stick with the CAP guideline. The good thing is if you ever get inspected and someone wants to make sure you're compliant, if you meet the CAP checklist, you should be good. But from a practical purpose, if you cannot get to 60 and you have too many cameras, too many sites, just provide good justification that, this is why you did it. And I'm sure any CAP inspector would, work with your reasoning and say, okay, that's fine. You've self-validated.
Thank
Can
you,
I just
Liron.
ask a question very quickly? You said 60 cases. or 60 slides. For instance, one case could be like 10 slides. And how do you deal with that?
Well, generally, I mean, it depends on how you practice. You should try and simulate real practice. To be honest, if you get a thyroid of 10 slides and they're all negative, that's a lot of work. And I don't say that's necessary to do 10 slides per case. I will tell you, when we validated our system, we had done that more than 2 years ago, and we did get a CAP inspector come through. We were criticized. We did do the 60 cases and we documented everything. But the CAP inspector criticized us, and I agreed, and we actually made a change. And the criticism was, when we pulled those cases, we pulled mostly positive cases, lymphomas, papillary thyroid carcinoma, etc. And we didn't have too many unsat cases, which is just blood, which is a good point, because to be honest, when you're doing telecytology, if someone shows you, a big diffuse large, cell lymphoma, it's easy. Oh, I can see that's lymphoma. But when it's full of blood and clots and negative, that's actually much harder. So what we did was we did boost our validation study with many more unsat cases. So when you pick those 60 cases, and can be one slide or multiple, depending on how you feel, make sure you have some unsats and challenging cases, not just the easy ones.
Mm-hmm.
Thank you, Liron. The next question will be for Mohi. It's about the exam and if there is any precaution taken for the glass slide session, because the slides are handled by multiple participants. We are talking about the ABP exam in here. Right? Can you unmute?
Yeah, we may be having some audio issues here. Let me see if I can do something.
Thank you. So, yes, we have been taking precautions in the exam center, wiping down all the microscopes, all the slides, and trying to maintain as much as possible the cleanliness of the exam center and the exam materials. I wonder, does that answer the question, Stefan?
Sure, thank you. The next question is to Maureen, and that's from my part. I think that Maureen has been one of the few people in our community that has contracted this disease. So maybe we should tell us more about what the experience is to go through this.
Yeah, okay, I'm happy to. Can you hear me?
Sure.
Yes.
I came back from the USCAP around the 4th or 5th of March, and about 2.5 weeks later, I started to feel sick. Now, as Dr. Barkham was very generous to share, I did just finish law school, so I'm always tired. So I have to kind of figure out if I'm sick because I'm sick, or if I'm sick because I'm sick of school, or whatever. What I experienced started out with a headache, a very severe headache that wouldn't go away no matter what I did. That was followed by a fever, about 101, 101.2, and a slight cough, but not anything special. But the symptom that was the most troublesome for me was myalgias. The myalgias were unbelievable. 9 out of 10, unlike anything I had experienced before. I kind of knew what I had, but I kind of didn't want to admit it. I phoned some friend of mine who were physicians who urged me to get tested. I gave up trying to get tested. Remember, this is in the 3rd week or so of March, and testing wasn't so available. And my thinking was, well, I'm probably not going to die. My breathing's okay. My chest hurt, but I wasn't short of breath. And I thought, if I go to the emergency room and I don't have it, I'll get it. So I decided not to go to the emergency room. And I told my colleagues at work, oh, it's just my annual bronchitis. Don't worry about it. Because I didn't want people to get scared. And then it didn't last very long, maybe 2.5, 3 days. They were miserable days, but I was never short of breath. I came back to work being extremely cautious, like OCD cautious about everything. Now I have a husband at home and a daughter at home, and I was concerned about them. My husband said he felt weird for one day, but for any of you who have met my husband, he is a little weird. So I didn't take much thought about he felt weird for one day. He's felt weird for 20 years to me. So then they started doing some experimental, I would say, research-based antibody testing. And I said, okay, let's do it. Let's see, did I really have it? and my antibody titers came up very high. And at that point, I urged my colleagues who were also complaining of feeling ill, having bronchitis, etc., you better go get your antibody titers tested. People had enormously, I thought for an old lady like me, I wouldn't raise any response. I had enormously high titer. So did my colleagues. We put ourselves on the list to donate convalescent plasma, but we're having difficulty with that because we never had a positive COVID test. Although I'd like somebody with more scientific knowledge than I to tell me how I could have high titers and no infection. That kind of subsided. The fatigue was tremendous. And I kept telling myself, that's because you're finishing law school. And by the way, just to comment on some of the things that Mo is saying, we have to take the bar. And no one has a clue how we're going to do that because we cannot maintain that physical distance that Tim pointed out for thousands of people to take the bar. So any of us who are in law school or finishing are having an issue with how we're going to get certified to the bar. So anyway, getting back to the fatigue, it's now coming out in some of the literature and in some of the clinicians I've consulted that fatigue is a consequence of this, as well as neurologic manifestations. One of our cytopathologists developed a tremor after his infection. It's now residing. It's now reciting, but it was the definite, visible hand tremor that caused him difficulty looking at his slides. So I think what I mean to say is that COVID can manifest itself in many different ways. I consider myself extraordinarily lucky. I didn't have any complications of it other than the fatigue, which is starting to go away. But I think we need to be sensitive to our coworkers who may have it, come back to work, be cleared for work, and be just plain exhausted, and give them a little bit of space to get better physically, and get better emotionally. It was bad, but it was only bad for a couple of days. Does that give you any info into it? Is it helpful?
Yes, Maureen, thank you very much for sharing your experience. Another question that we have for Tim is, how do you apply your rules for a laboratory worker who worries to go to work? What do you do for that situation? And we have to unmute you.
So it sounds like your question is one, if you are concerned about a colleague. Now, is this someone who needs to come into work? Is that what your question is? And
yes,
they don't want to?
The question is about the laboratory worker. How would they cope with their worry to go to work?
Yeah, so I think that in that situation, especially if they are doing work where their physical presence is absolutely required, I think that it's important to have a conversation with that person and to validate their feelings. Because remember that what is really critical to a sense of psychological well-being, first and foremost, is a sense of autonomy. And that's part of what makes the situation so challenging, is that so much is now out of our control. And so now if people are being told to do things that they don't want to do, that's just another dagger that's reinforcing their loss of control. So I think that it's important to find out more specifically what their concerns are, and then to outline the provisions that are in place to respond to that, and to let them know, what precautions the lab is taking, what other measures are in place, and continue, and then step by step, asking them to tell you more about what their concerns are and what the lab is doing to address them, and help them understand if maybe some of their concerns are unlikely, and those that are likely, again, it's all about helping them to focus on what truly is within their control that they can be doing to take care of themselves. But I think that having a dialogue, validating their emotions, and making sure that their concerns are heard is a very good place to start to open up that dialogue, and then walking through what steps are in place to address those concerns.
Okay, thank you very much. Now let me ask Dan something. In people like Maureen who have high levels of antibodies and who have presumably had the disease, because otherwise you cannot get the antibodies, is that something that would make her be more relaxed because she will not get it again, or is that something that shouldn't make her more relaxed?
Yeah, everybody's careful about over-interpreting what a positive antibody test means, because we haven't studied it yet. Likely, if you have a disease, an infectious disease, and you recover, then you're likely immune for some period of time. Sometimes that's lifelong, sometimes that's, a few months, but it's not clear yet what that means for COVID-19.
Thank you very much. I don't have any other questions, except for one for Liron. It's about fatigue from Zoom. Do you know anything about fatigue from Zoom and what should be done about it?
I guess I have to ask my 16-year-old daughter who's on Zoom all day, every day for school. I have been told actually that Zoom is very user-friendly compared to many other systems out there. Our hospital prefers something like Microsoft Teams. It's much more HIPAA compliant, less risk of cybersecurity attacks, etc. But our residents have asked the program that they prefer Zoom. It's much more friendly, better to teach, etc. So I would say that it depends on the application. If you have an easy application, what we're using now is great. You can see everyone, the Brady Bunch appearance, and it's, it works well. It also depends on what monitor you're using, the ambient environment that you're in, etc. To be honest, Stefan, I don't know the answer to that because this is a new virtual world for all of us. Everything's moved virtually. So I don't know. I do realize the user interaction is different. I'm using it myself all the time. But in some regards, I might say, although I do miss the one-on-one interaction with trainees, etc., I'm also enjoying some peace and quiet, too. And logging onto a session and, I can pause when I want, I can step out when I want. Can't do that often, when there's two people in my office and a multi-headed scope. So there are some benefits to that. But I don't have a real answer because, it hasn't been formally studied that I'm aware of.
Thank you very much, Liron. Let me just
talk on that a little bit too. Like, what do you think as a psychologist's perspective?
Well, I can tell you, having converted all of my classes to Zoom, at first I thought, oh, this is actually going to make it easier. But I have to say, I think I was more exhausted after doing a Zoom class than I was doing it in person. And I think a part of it is because when we are with people like physically in person, we are able to extract some level of energy that keeps us going. But when you have to spend an extended period of time staring at a computer screen for, potentially hours in a day, there's just something different there that is exhausting because you're not able to get that real-time feedback and you're sort of always in the back of your mind trying to guess for yourself what the audience's reaction is to things. And I think that itself is a cognitively taxing exercise. So I think that there are some benefits in terms of convenience, but I think that it's also important. I mean, what I've suggested to my colleagues is don't schedule Zoom meetings back to back to back, allow a 10 or 15 minute window in between them to get up, stretch your legs. I have a colleague in the public health school at WashU who says that sitting is the new smoking. We shouldn't be sitting for extended periods of time. So, taking an opportunity to get a bathroom break or stretch our legs, get a snack, do something, because if it's an entire day of Zoom meetings and classes and things back to back, that can really take a toll on us.
Okay, thank you. Thank you very much. And if anyone of you of the panel wants to add some last words because we are out of time, otherwise I will remind everybody that this whole session has been recorded and is available on the YouTube channel. I don't know exactly how to get to that. But
1951. That was when ASC was founded. Cytopath 1951.
Okay. At any rate, thank you very much for all the members of our panel. And if you want to add something now, please.
Thank you, girlies, for putting this together. I think it was great.
Well, thank you all for joining. Thank you, Dr. Pambuccian, for moderating. Thank you all for agreeing to do this. I know this was an extra meeting among all your other things that you have to do, but I'm sure whoever is listening to it was able to gain from your valuable insights and your viewpoints. Thank you.
Thank you.
Bye.
Thank you all, and see you next time on the webinar.
Virtually.
That's right.
But I miss you all.